Back. A little bit more thumbs in the back. Help me out. We good? Kind of? How about like this? Oh, I don't want to eat the mic, but okay. Get started? Okay. Yeah, let's do it. Let's get started. So I know folks are slowly coming in, but hello and welcome. If you were here yesterday, welcome back. If you're joining us today for the first time, welcome to the 14th Annual Family Medicine Midwest Conference. Still hear me okay? Yeah? Still no? Let's do this. Better? Just hold it? All right. Welcome or welcome back, now that you can hear me, to the 14th Annual Family Medicine Midwest Conference. My name is Dr. Carl Lambert. I'm a faculty member at Rush Medical College in Chicago and part of this year's planning committee. We hope you've recharged over lunch, that you're not too full, and you're ready to glide into the home stretch of our afternoon events. You've been able to explore the amazing variety of sessions and posters throughout the weekend, and this is the time and the place to embrace what family medicine, why it's so amazing. It's our diversity of people, the experiences that we bring, and the care that we provide for patients, often from very vulnerable populations. Our agenda of breakout sessions and posters and the results of those are due to dedicated review and selection process of the Family Medicine Midwest Education Subcommittee, which I was honored to chair alongside Dr. Jonathan Dickman, who will be up here in a second. All of our work was done remotely over the summer, so many of us are meeting for the first time in person, which has been a pleasure. Also, if you served on the committee, any part of the planning committee, and you're here, please stand up, give a wave, so that we can acknowledge you as such, please. Give a round of applause. It took a lot of work. Thank you. All right, all our committee members are listed in the Family Medicine Midwest app and our Family Medicine Midwest website. And thank you to everyone who's been on the committee for just all the hours of volunteer work that you've put into this. Finally, before I pass it over to Dr. Dickman, we know that everyone can't possibly attend every session, so be sure to have the app. Everyone got the app? The Family Medicine Midwest app? Very useful, very user-friendly. Make sure that you get that or just visit the event website and download any session resources, or there's contact information for the speakers should you want any contact with them or have questions afterwards. So with that, I'm going to pass over to Dr. Dickman.
All right, thank you. How many of you all like to receive feedback, right? We have a lot of residents always asking for more feedback, more feedback. I've got good news. We also like feedback. So what you want to do whenever you're attending an event, you're using that app. So everyone here should use that event evaluation button on the app to submit your overall conference feedback. Also, please submit the short breakout session surveys for each one that you attended. You'll find the survey button in the schedule listing for each session, along with the speaker information and session handouts, including for the plenary presentation that you'll hear, and that also happened yesterday. Those who registered on site will be able to submit evaluations once you're added as an attendee to the event app platform later today. Active physicians will use the Claim CME credit button to submit their CME credit for after the conference. And if you love reviewing and scoring abstract submissions, we have a place for you at the 2026 Family Medicine Midwest Conference. There's a link on your app resources tab to sign up for next year's conference planning committee and education subcommittee. The most important thing you'll need to know is that the next conference is September 11th and 12th in Indianapolis. We're also looking for students and residents here today who are interested in applying to serve on the Foundation Board of Directors for the calendar year of 2026. Information and the application are on the Family Medicine Midwest website board page under the About Us tab, and also on the resources section of the conference app. The deadline to apply is December 1st. And now to introduce the closing plenary presenter, please welcome another Family Medicine Midwest board member, and we found out yesterday a very, very good cornhole player, Dr. Thomas Hahn.
I usually call it bean bags, but Dr. Dickman is also very good at cornhole / bean bags. So is Dr. Lambert. That's why they asked us all to give these intros. So like Dr. Dickman said, I'm Dr. Tom Hahn. I am the program director of the residency and a faculty at the University of Wisconsin Family Medicine Residency Program in Madison. And I have been a board member on the Family Medicine Midwest Foundation for multiple years, along with other long-serving leaders. If there are any board members here, I'd love you to stand up because I'm just going to list off your names. So some of the long-standing board members are Dr. Andrew Slatengren, Dr. Rashid Patel, Dr. Alicia Vasquez, Dr. Lisa Pfeiffer, Dr. Jake Pronusky, and the incomparable Dr. Janice Benson, if you're here. And then I also would like to thank our newest board members, who are Dr. Ruben Hernandez and Dr. Roxanne Smith. Let's just give them all a round of applause, please. And we also have a resident board member, Dr. Catherine Phelps, and a student member, Katie McLaughlin. Let's give them a round of applause, too. And we might mention this later, but I'll put a quick plug. We always get a new resident and student member every year, and so if that's something you might be interested in, residents and students, please keep a lookout for more information about that. In addition to being on the board, I'm also very proud of the ongoing role that the University of Wisconsin Department of Family Medicine and Community Health has played in the success of this annual conference since the start of Family Medicine Midwest. I've also seen many medical students who attend this conference match into our residency programs, so it truly is a great way to bring together people interested in family medicine in the Midwest. On our campus in Madison at the University of Wisconsin-Madison, we have hosted 2 Family Medicine Midwest conferences. Our residency program is an exhibitor with the residency fair every year, and we also support our medical students who attend the conference every year with scholarships. So I mention those things because I challenge those of you who are leaders in family medicine institutions to join the foundation as an organizational partner. Details for how to do this are on the Family Medicine Midwest website, and our board and staff are here to tell you more about that. Next, I just want to transition and present a very important award that was actually announced yesterday, but I want to present the Dr. David Deasy Award to medical student Lauren Harrison. Lauren, if you want to come forward. And I'm just going to say a couple quick words about the award. So Dr. David Deasy, when Family Medicine Midwest was formed in 2010, it was formed by a group of leaders from Midwest institutions, and Dr. David Deasy was one of the leaders from the University of Wisconsin who was involved. His job was leading medical student education and family medicine at UW-Madison. He passed away a few years ago, but to honor him, his family created a scholarship that really recognizes students who are committed to underserved care and especially rural health. And so we are so pleased this year to have Lauren recognized for her accomplishments, and she, I think, has 2 posters this year, so we encourage you to check out her poster this afternoon. And with that, I'm going to give Lauren her well-deserved award, so congratulations. Okay, the final way that the University of Wisconsin has contributed to the Family Medicine Midwest conferences is through our exceptional family physicians who have served as plenary speakers. and this year is no different. So today, I have the privilege of introducing another of my colleagues who is our closing main stage presenter for Family Medicine Midwest 2025. Dr. Yohualli B. Anaya is an associate professor at the University of Wisconsin School of Medicine and Public Health, Department of Family Medicine and Community Health. She earned her medical degree and Master of Public Health from the USC Keck School of Medicine in California and completed residency training at the UCLA Family Medicine Residency Program. Dr. Anaya is co-director of the Center for the Study of Latino Health and Culture, Accelerating Leadership Institute, and the 2024 to 2026 National Academy of Medicine Fellow to advance state health policy. She is an associate editor for the journal Family Medicine, a faculty expert for the Latino Futures Lab, and a physician board director for the UW Health ACO Board of Directors. Dr. Anaya's research interests include Latinx and immigrant health, investigating and addressing aspects of healthcare delivery that impact care accessibility. As core faculty at the University Madison Department of Family Med and Community Health, she teaches residents and medical students and serves as a primary care physician at an FQHC. Dr. Anaya was a 2024 NIH National Institutes on Minority Health and Health Disparities Research Institute Scholar. That was a lot of words, but well-deserved. Clearly, currently, we are in another era of uncertainty in healthcare. 5 years ago, we navigated the COVID pandemic, which upended and tested our healthcare system in ways we had not experienced in our lifetime. Now, we must continue to navigate through new challenges and uncertainty today, and we will have to do it again in the future. To share her vision on how being rooted in our values provides the clarity and strength to lead through uncertainty, drive change, and help shape the future of healthcare, please welcome Dr. Yohualli Anaya.
If I had known they were going to read the entire bio, I would have made it shorter for you all. Sorry. I am going to try and see if you can hear me doing this. Can you hear me? Yeah, okay. Well, thank you so much for having me, and I feel incredibly honored to be with you all. I'm going to turn on this. Yeah? Okay, perfect. I've got no disclosures. So, meaningful impact. Over the next hour, we'll be having a discussion around values, what it means to put your values in action, and how doing this can help you lead through uncertainty and shape the future of healthcare. And my goal is that by the end of this session, you'll be able to identify at least 2 of your own values. How do you define leadership? If you were to close your eyes right now, what images pop in your mind when you envision a leader? What does a leader look like? Maybe we think of our deans, maybe our department chairs, maybe our state governors. When you envision a leader, can you also see yourself as a leader? Maybe for many of us, that exercise does not conjure images of ourselves. Maybe you didn't even think of yourself as a leader. Maybe you think, I'm just a medical student. I'm just a resident. In your cadre of leaders that came to mind for you, and now considering yourself as a leader, I want you to think about what defines a leader. What is leadership? Let me tell you about where my leadership started. This is a picture of me and my mom. Little me is so cute, right? As I've studied leadership, I've realized that my leadership lessons began early in my life. This is the person that I saw modeling leadership every single day. But I don't know that until I studied leadership, I recognized that she, even at this early age, that she was my leader. My mom was my leader in my nuclear family, in my extended family, in the spaces we entered. To this day, she has that way about her that leadership radiates from her. My mom was a teacher in Mexico. After migrating to the US, she was no longer able to practice as a teacher. The lack of transferability of her teaching credentials and her limited formal instruction in English didn't stop her. Early on in our time in our states, to help bring income into our home, she had to leverage some of her other gifts and talents. So she enrolls in English education for adult learners, and soon, in addition to being a student there, she develops a mini business, selling her amazing breakfast burritos and tamales to other learners and to her teachers. After some years, my parents were well integrated into our community, including our church community, and that opened up additional opportunities for her leadership. She leaned into her skills. She offered her skills in music theory, in teaching, in education and theology. And over the years, she created a role for herself in music education and formation of leaders of congregational song for the Los Angeles Archdiocese, the single largest archdiocese in the United States. My mom, a Latina immigrant, like those now allowed to be profiled across the country. With pride, I recognize her as my earliest model of leadership. And one foundational reason for where I stand today. I'm a physician researcher, and my vision is healthcare access and accessibility equity. My vision is grounded in my values, and together, they are the foundation for my leadership and my work. I'm a leader grounded in impact and excellence. My intention is to be impactful through outcomes that benefit those that are most marginalized, and to produce the highest quality work. I'm a leader working towards the future of healthcare delivery and using my voice to advance healthcare delivery. That brings me joy and meaning. I also value developing leaders and creating space for these leaders to use their voice, because I see this as pivotal to advancing my vision. I believe collaboration and community are core to being impactful. Finally, I value integrity and diligence in myself and in others. And these values have allowed me to achieve goals that I've set in my academic and professional path, whether it was getting into medical school or earning the grant that has facilitated some of the research that I'll describe a bit later. These are my leadership values. They represent my core, my compass, my why, and the principles that drive the wide span of roles that I play in my life. My personal values. Joy. Can you see the joy in the face of those two beautiful little children on the left? Health, family, culture, the beauty and the renewal that exists in nature, that brings me meaning and fulfillment outside of work, and which sometimes I have to work hard to integrate. Whether it's for that renewal, sometimes for full-on strength that I need amidst those day-to-day challenges. And in the case of my kids or my health, because these are integral to the good work happening in the future, whether it's work through myself or one day through my kids and other leaders that I develop along the way. So why am I giving you a rundown of my personal and professional values right now? A critical part of leadership is first knowing yourself. Because how can you lead others without first leading self? You each wrote a personal statement for college, for medical school, and many of you probably referenced your values and your why. Maybe then you didn't realize that that's what you were doing. Maybe you didn't appreciate the importance of having that clarity that you captured in those statements. When's the last time you revisited that personal statement, that personal motivation, your compass, your why? As I've continued to study leadership and develop my own leadership skills, I continue to learn and to see just how important clarity of our values is for helping us find direction during our hard days, for making decisions about what residency you're going to rank at the top, for getting clarity on when you're asked to do one more thing. What opportunities are you going to say yes and no to amidst our busy, busy, busy lives? Because often, the more alignment that we have between our values and our actions, our decisions, what fills our day, the more we'll reduce that background unease, sometimes even anxiety that arises when we are less aligned. And the more resilient that we become to challenges that arise. Because challenges will arise. Challenges inevitably arise throughout our lives. And as leaders soon learn, encountering crisis is a standard part of the life of leaders and institutions. Whether it's a pandemic or some other source of disruption, uncertainty. In crisis, we face the unfamiliar, the unexpected, and as a result, they tend to distract us. And that results in further turmoil. By nature, crises challenge our core. Therefore, regrounding in our values, who we are, and what it is that we care about is particularly important as a first step in times of crisis. Doing so will not only be studying for you, it will set us back on our path of purpose and with the strength to proceed. I'm a researcher who's focused on advancing healthcare delivery for some of our most marginalized patient populations, those that are forgotten, in some cases excluded from our systems of care, and even depicted as undeserving and undesirable populations in the US and in its systems of care. There are days that today's climate feels like an existential threat to my identity. There have been days in which the day's headlines have been so jarring to the point of my questioning if and how to proceed along the path I had envisioned. By nature, crises challenge our core. Impact and excellence, using my voice to advance healthcare delivery, creating space for leaders to lead, collaboration and community, integrity and diligence, family, health. It is in these times that I turn to these for coherence. I align myself in my actions, and I'm fortified, and then I can proceed. And sometimes I even find new opportunities to lead and generate impact. So let's talk about leading through uncertainty. What does that look like to align actions with values? What does that mean? And how does that give us capacity to help shape healthcare delivery? Let me tell you about Mr. F. Mr. F is a hardworking, working-age Latino male. He's got diabetes, and he presents to the UCLA ER. That's the hospital where I used to attend. His chief complaint, a foot wound, and our family medicine teaching service is called for his admission. Mr. F works hard. He works 2 jobs. He works at 2 local restaurants in Santa Monica, and because those restaurants don't offer full-time positions, he doesn't have access to health benefits. Now, it's the pandemic, and the restaurant at which he works the most hours shuts down, and he loses his job. Because of this, he's been collecting and crushing cans to supplement his limited income. He states his clinic has not been seeing patients in person since the pandemic. And so he's only had access to phone appointments to refill his medications. No doctor has seen him or examined him in many months. He hasn't had an A1C in many months. And today, he's here in the emergency room for evaluation and discoloration of a toe on that right foot that he's been using to crush cans. He doesn't have pain, he feels well, but it just won't get better, and so he decided he had to come in and be seen. He's had an ulcer on the bottom of his foot since May, but he was too scared to come in and seek care for it because of the pandemic. On our exam, he's got a deep ulcer. The x-ray shows osteomyelitis. He ends up requiring a significant amputation. As I mentioned, his livelihood depends on his physical ability to walk and bus tables. He has emergency Medicaid, but he's not going to be able to continue to receive care in the outpatient UCLA podiatry offices for his care post-op. So how do we keep Mr. F healthy from here? Will his foot be able to heal without complications? Will he have appropriate evaluation of that foot over the coming months? Are we setting him up for success? Or are we failing him? Setting him up for failure? How did we fail him as a healthcare system over the course of the months over which he did not have access to in-person care, and before then had limited access? He works 2 jobs. He doesn't have the privilege of health benefits. In Mr. F's story, and in the stories of my other patients, what I see is opportunity. Opportunity to make things better. Opportunity to lead, to improve care delivery, to improve access, and to improve outcomes. That's why I do research. That's why I do leadership work and policy work, because I'm grounded in that overarching value. So when I saw what was happening to my clinic patients who were only being offered phone visits amidst the pandemic, what was happening to Mr. F, I couldn't but move my values to action and challenge the status quo. When systems fail my patients, I'm inspired to imagine possibilities for the future. That's what keeps me going, knowing that my work and my voice is shaping our future. Amidst the height of the pandemic, when we shifted to telehealth out of necessity, who was our telehealth care delivery system built for? In those early days, who was designing our system? And who was in their mind as their patient population? Was it Mr. F, a restaurant worker? Or was it you and I, who can jump on a video visit from our laptop in between a meeting? I don't think anyone intended for this restaurant worker to be receiving his diabetes care through a phone visit. But when his clinic, like our own residency county clinic, pivoted to telehealth, and the only telehealth, quote unquote, that we offered was phone visits, we set up a system of care delivery that was ripe for opportunity for improvement. From the problems that I was seeing, it was easy for me to see what needed to change. So I started to study telehealth and telehealth policy, and I started leveraging my experiences that I was having as a family physician, as an educator, and those stories of my patients. And so I started writing this policy brief. And I put on paper the barriers my patients were facing. Devices. My patients didn't have laptops or computers at home, but many had smartphones. Well, it turns out we've got actually pretty good estimates on access to smartphones across populations. So, to ensure that my patients could access video visits amidst the pandemic, they needed platforms that allowed them to connect to their video visits through their smartphones that they actually did have access to. English-based systems. Though Spanish is the second most spoken language in the US, with deep historical roots, where Spanish has been the official language or co-official language in various states as early as the 1500s, through which government documents, even ballots, were common in Spanish, even in the 19th century. Yet many of our institutions' portals and apps are accessible only in English. Recently at UW, we've had the implementation of Spanish language accessibility for my chart headers and menus and activities, a wonderful and much, much needed change. Next, I hope, will be the ability for us to communicate through the patient portal in our patients' preferred language. I imagine the possibility of using AI to help with the back and forth interpretation in my chart messages. Because currently, when our patients reach out in Spanish through my chart, they get a message telling them we cannot help them in Spanish. They're asked to call in, creating additional barriers for their access, and additional staff labor in the back and forth of the phone calls that then ensue trying to reach the patient. During this time, there was also a lot of policy level issues that were affecting telehealth access for all. They included coverage and broadband access, among others. And so this policy brief that I wrote, again, mind you, what I was seeing in clinic in that policy brief attracted the attention of many interested parties in policy. And I was invited to share these findings with the LA City Health Commission. And it continued to gain traction, drawing invitations that drew me into spaces that were outside of my comfort zone, that now I love, where I could influence the status quo of our telehealth accessibility. When I presented before the California State Assembly Health Committee as an invited expert, you can bet that that felt high stake. You can bet it was daunting. It was a space marked by expertise and influence. It was hard to find footing at first. But bringing my leadership voice into this space, though intimidating, captured the interest for more key members. And shortly thereafter, I received the invitation from Assemblymember Aguiar Curry to present at an informational hearing for AB 32 on telehealth policy in California. I was able to testify and influence AB 32 around telehealth policy for California Medicaid. And this was when I realized the power of using your voice amidst crisis. A voice that's grounded in values and vision to effect change, to create systems that can benefit all, not just a privileged few. And using your voice can come in many forms. Sometimes it's writing a perspective in a scholarly journal. Maybe it's an op-ed. Maybe it's research. Leveraging our voice via different levers for different audiences, shifting the narrative, and bringing your envisioned future to life. My vision is healthcare accessibility. I was 5 years old when I decided I wanted to become a physician. Back then, I thought I wanted to become a pediatrician. Of course, I didn't know about the powerhouse in family medicine. At that very young age, I had to show up as a leader in my clinic visits with my pediatrician. My mom didn't speak English. There was no translator. I was 5 years old, navigating that as the primary person in that encounter. So quickly, even then, I discerned the value of language concordant capacity for healthcare accessibility. That deep, deep value of language concordant care. Opportunity. Now, I work on research that explores different facets of this value. A couple of years ago, the ABIM sponsored a study on trust that helped identify that Latino adults report the lowest levels of trust in their doctors. There's a critical need to identify factors that interfere with trust in science and medicine. I'm sure you all can agree. Because low trust is linked to delays in care, low treatment adherence, and that increases premature morbidity and premature mortality. But as is common in research broadly, Latino voices are often not included and greatly underrepresented in the evidence base that helps us understand the mechanisms and pathways for health. And so I started imagining possibilities and materialized these possibilities into a grant-funded study to hear about what matters for trust and trustworthiness from the voices of our patients. And this is what we're starting to learn. This is a text-heavy slide. And at the top, we have the Spanish, I think, a value to have represented as it was voiced by our participant. And down in the lower is the English translation. Trust is when they say, look, this is going to help you. I ran some comprehensive tests, and we've come to the conclusion that they explain more to you, that you come to understand what you have, and that they speak to you like in your language, right? Because sometimes there are words that you don't understand, and sometimes you kind of feel embarrassed. You just kind of say, uh-huh. But yes, that they explain the cause of the illness, and also the consequences of not undergoing treatment, how you can get better, what you should do, then that gives you more trust because you understand it, and well, you can try to take care of yourself. And also, like when they prescribe medications, what are the consequences of taking that medication, right? Because sometimes there are medications that, well, can cause other things. This is another participant. So I was getting used to being treated badly, you know? But then another doctor came along. Well, she was worse than the one I had before. So I stopped going. I stopped going to the doctor. I said, no, I am not going anymore. I stopped taking my pills for a long time. Until later, I started feeling really unwell, and I thought, I have to go to the doctor because I don't feel right. And I went. And they told me they had in my file that I have high blood sugar. What happened? They asked. Why aren't you taking your medication? And so I told them, it's the way I see the doctor treat me. I don't feel comfortable. You don't even have the trust to tell them what's going on with you because of the way they treat us. And I've realized I'm not the only one. So I think, well, maybe it's because I'm Latina or because I have a different skin color, right? That's why they treat us like that. But at the end of the day, we're people. This is the voice of the mom of a pre-medical student who works in my lab. These voices are echoed in the existing literature of Latino patients' healthcare experiences. This is a scoping review we've worked on over the last year that has identified key trust domains based in Latino patients' healthcare experiences in primary care, at least from what we currently know. The literature is limited. We reviewed over 4,600 papers. Only 28 met inclusion criteria, and only 3 had a primary focus on trust or mistrust in Latinos. We found that, like for other populations, the domain of communication is important for trust. And for Latino patients, one dimension of this is language concordance. Patients bring up examples of when the interpreter does not accurately or wholly translate what the patient is trying to communicate. Experiences of mistreatment from their doctors for their limited English skills. I felt very bad because the doctor asked, how long have you been here? And I said, so many years. Well, why can't you speak English? Because I came here to work, to raise my family. Time slipped by. I didn't know that was a sin. The dimension of respectful communication and emotional safety. Quite simply, it is because the person I see has an interest. The person is interested. Then you feel more open. And the effect of compounding negative experiences in care on patients' ability to trust us and the clinicians after us. So I believe The U.S. workforce is another opportunity to advance healthcare delivery. This is a study we worked on the summer before last, exploring what we knew about barriers and facilitators to shared decision-making in diverse populations. Characteristics of congruence arose as a theme. And again, the cues of the deficiencies in our healthcare delivery: lack of interpreters, lack of appropriate translation even when they're provided, impediments to in-depth treatment discussions. The barriers to the type of communication that we all hope for our own families. Barriers to developing relationships with clinicians, and the impact of prejudice, and sometimes of cultural discordance on trust. But without trust in your clinician, how can there be a therapeutic relationship? And though I think those who share values similar to mine can agree of the humanistic aspects of why trust and shared decision-making and therapeutic relationships matter, there is also a financial argument to why this matters. Lower annual expenditures occur when more shared decision-making occurs, and that effect on expenditures is amplified when clinician and patient relationships are racially or ethnically concordant. And those reduced expenditures don't come at a cost of a negative impact on health outcomes. Concordance makes for an effective clinician-patient relationship that results in fewer ER visits, fewer hospitalizations, lower total healthcare expenditures, and lower outpatient expenditures. So how are we doing with that physician representation of, for example, Latino physicians who can help contribute to these positive outcomes that we're seeing in these ethnically concordant clinician-patient relationships? And how does that compare to the US population? Well, though Latinos make up 18% of the population across the United States and up to 40 and almost 50% in other states like California and New Mexico, Latinos make up only 6% of the physician population. And as a Latina physician, I am part of a mere 2.4% of the entire physician population. This number is stagnant, by the way. From our most updated analysis, there is no significant difference between these estimates and more recent estimates. There's an interesting pattern in the representation of Latina physicians. A higher percentage of Latina physicians are immigrants compared to the general US Latino population. When was the last time you heard about the importance of immigrant Latinos contributing meaningfully to our US healthcare system, filling workforce and physician shortages that help improve access for all US populations? I know that's certainly not the narrative being leveraged in the targeting happening across this country right now. But thank goodness for the language capacity contributions of Latina physicians in the US workforce who are 35 times more likely to speak Spanish than their counterparts. Spanish skills that, as you saw, help contribute to trust building, in-depth treatment discussions, and shared decision-making. Like among physicians, there's a similar lack of representation among the biomedical research workforce, where Latinos, we don't even make up our own category there. We're lumped into the other category. Yet, representation matters for the questions that are asked, the diversity in thought that spurs scientific advancement. I'm grateful to be able to be a representative voice in spaces like this here on the left, as a fellow at the National Academy of Medicine, where I am able to be in spaces and committees of influence. But as one of 2%, I and the rest of us making up this small percentage can't be split across all of the areas where diversity of thought and lived experience is needed. And that's why one of the paths through which I aim to advance healthcare accessibility is by addressing the need for a workforce that can provide care for all and that can influence care delivery for the better. When I made my transition from my last institution, I received this incredibly thoughtful gift that also showed me I was valued and seen, and is a reminder when I need it that my hope, my goal, my purpose, including in this room today, is to cultivate leaders. Each of you here today is a leader. And part of my intention in my time with you is to nurture you as a leader. Because I need you out there imagining possibilities and materializing our collective future. Stepping in as the co-director of the Accelerating Leadership Institute has been an area of tremendous growth for me. When I was invited to co-develop the Institute, I questioned how I could possibly be advanced enough in my own leadership to be tapped for such a role. But, like I did as that 5-year-old in the exam room, who likely felt similarly not yet equipped, apprehensive, unsure of myself, I stepped into the opportunity. And as my 8-year-old son likes to say, I said, "Let's do this." And I've learned that despite my uncertainty about my readiness, I do have much I can add. Over the last several years, we've built up the Institute, trained 4 cohorts, 93 leaders across more than 25 different healthcare institutions. We developed a data-driven 4-month curriculum that prepares and catalyzes leadership. These alumni are doing some incredible work advancing health for all, far surpassing any of the work that I am doing. And I'm privileged to be able to model this in a variety of spaces of influence, often especially meaningful, and I think even most influential when I get to use my voice to develop leaders through their early stages. This here on the bottom, that's a UCLA cohort of my former residents and residency staff that are now alumni of the Leadership Institute. One of these leaders has now started a medical group to expand FQHC workforce in medically underserved areas in California. He's managed to double the healthcare workforce in just 2 years. I was recently catching up with another one of the leaders in this picture who experienced some challenging times during his residency training. If the residency program could only see him now. He's the ambulatory director in an LA residency program, and he's developing patient education materials like he and I used to dream about during his advising sessions. Or maybe this class of high school students, one of the classes to go through the FM Bridging the Gap program, a pathway program that I founded and co-directed during my time at UCLA, and now, it's hard to believe, but is 10 years in, developing students from the local public high schools in an effort to increase students from disadvantaged backgrounds in the pathway to healthcare. I started developing this program as a third-year resident, using skills and knowledge that I'd gained during my MPH to create something that was theory-driven. Because to be effective, such programs must not only be well-intentioned, but also evidence-informed. Students who are already educationally disadvantaged deserve our best efforts to provide them more than what is easy to implement, but what will be effective for what we aim to achieve through it. This program is now in the capable hands of one of my other mentees, continuing to do what it was built to do, and probably even more under her leadership. These are just my examples of my values and how I've lived them out over the course of my own leadership journey. What are the values that are important to you? To be able to live out your values, you have to first identify your values. You have to know what your values are and have clarity about them. Maybe you're far ahead. Maybe this is something you currently have clarity about. I sure didn't when I started doing leadership work. Maybe it's not something that you have clarity about. But getting into a space where you feel like you found your groove, that requires us to know what it is that we care about. Because life and work, they're going to throw you many things that'll keep you busy and distract us. But when those things keeping us busy are not our values, that's when we feel exhausted, anxious, burned out, frustrated, even resentful. Let's say you value family time, but you're not currently getting much of that. You probably feel out of sync. Instead, I want you to have a feeling of steadiness. Sometimes even the ease that can come with alignment and equilibrium between the life you're actually living and the values our inner selves deeply desire we were living. I've given you a few of my own values as examples, and the list of potential values is infinite. This is one example list to get you started. And hopefully you can actually read them, because I want you to look through this list and find the ones that most resonate with you. Maybe it's freedom, maybe it's confidence, community, maybe it's efficiency, being efficient on rounds, maybe it's financial stability. There is nothing wrong with valuing financial stability, well-being. So we're going to take a pause. You actually are going to look through this list of values and see if you can find at least two that resonate with you. If none really resonate, then you're going to do extra homework. You're going to come up with some of your own. I want you to ideally have two values chosen when I go to the next slide. So I'm going to give you a moment. All right, going once, going twice. So if those values that you found up there are important to you, how are you currently demonstrating that they're important? Are you currently more or less aligned with your values? This is another moment of pause, one that I actually want you to take to leverage for some reflection. We don't have many of those moments for pause Who has that luxury of taking a pause? So this is it. This is your moment of pause. So maybe you want to close your eyes, maybe you don't, it's all good. But reflect. If those values are important to you, how are you currently demonstrating that they're important? Are these values what is filling up your time right now? Now, whether or not you feel more or less aligned with your values at this time, I want you to turn to the person next to you and answer this question. What might you do to put your values in action to be able to live out your why? You're actually going to turn to the person next to you. You're actually going to pair share for 2 minutes. You will only have a minute a person. It's not very long. And I'll let you know when it's time to switch. It is time to switch to the other person. Thanks for playing with me in this space, y'all. There's a lot to think about, huh? My hope is that through the course of the last hour, and hopefully through that very brief discussion that you just had with your partner, that you've discovered something about yourself. When we can more clearly see who we are and what we care about, the possibilities to continue despite adversity and crisis, they become our pathway forward. You might know a song that says, I can see clearly now, the rain is gone. It's gonna be bright, a bright, sunshiny day. what exciting possibilities are you going to imagine for the future? For yourself? For your families? For your patients? For Irving and Annie, it was workforce development. For Edward, it was patient education and residency leadership. But maybe even like Edward, when I recently spoke to him, you can't yet imagine the possibilities of your future growth in leadership, despite him even actually having that leadership role as ambulatory director, and having been through the Institute, where we do these exercises of knowing who we are and what we care about. It takes intentional pause and reflection to know who you are and what you care about. And those possibilities that you can imagine become more apparent, more concrete and tangible when you ground in those values. Who you are, what you care about. I'm full of hope, and I'm excited for the future of family medicine, because each of you are part of that future. Thank you so much for having me.
Give another round of applause, please. Dr. Anaya, thank you so much for the work that you do. Poignant, meaningful, you sang to us, all sorts of things, so we're grateful for you. So I do have a couple of announcements on behalf of the Planning Committee before we move forward with the rest of the day, so please bear with me. After we finish here, we do have our final poster presentation session of the conference. It kicks off at 3 o'clock. You can also take another spin around the atrium to visit our supporters, learn more about these organizations, employers, and companies, and thank them for supporting family medicine. Also, those of you who do need to prepare for the residency fair booth, you have time to finish setting that up before the doors open to our prospective residents. Our final conference is, as we just said, the residency fair in the ballroom. We have over 50 programs represented in that room, so do pace yourselves. It probably will get crowded. Give yourself time and space as needed. It's tight. So again, do take time to go to the poster sessions in room 105. Also, if you're a student doing double duty presenting as well, don't fret. You'll have time to do the residency fair. Don't worry. If you're working with a residency program, the poster session is obviously strategically great to interact with some prospective residents who are presenting this afternoon. Thank you to all our presenters, supporters, exhibitors, our committees, and the Family Medicine Midwest Board of Directors for all their contributions. Also, next to last announcement, this is based on our staff members. For our practicing physicians, have you heard of the Know Your Worth initiatives through the AFP? Raise your hand if you heard of that. Perfect. Did you fill out the survey? Okay, maybe I have not. So, so if you haven't, ask a staff member. It's just a way to collect information about compensation, benefits, all that different data to help to advocate for our specialty better. So if I'm the only one, I will do that or spread the word. But nevertheless, I'll end with this. We wish you a safe travel home, whether that's down the road or in the air. Take care of yourself, stay connected, reflect on your values, keep exploring and embracing all that family medicine has to offer and why it's so amazing. And we look forward to seeing you next year the same time in Indianapolis. So please do come, tell people, tell your friends, all those things. So with that, have a wonderful afternoon. Take care of yourselves.